Right, so we're now at the top of the hour. Again, we'd like to thank you for attending this IAS-USA webinar. Today is Tuesday, January 17th, 2023. My name is Jose Francisco, and I'm a project manager at IAS-USA. We are excited to cover today's presentation on breast and chest feeding among individuals with HIV. Where have we been and where are we going? We are delighted to welcome Dr. Elaine Abrams from Columbia University in New York, who will go over our introduction slides and moderate the question and answer session at the end of this webinar. Welcome, Dr. Abrams.
Thanks so much, Jose. I'm delighted to be here today. You can advance the slides. So disclosures for the content on the web board are listed here. And disclosures for the presenter, moderator, and peer reviewers are listed on this slide. The IAS-USA designates this live activity for a minimum of 1.25 CME credits. The webinar is also approved for 1.25 hours of ABIM-MOC points and nursing, pharmacy, and pharmacotherapy credits. Generous support for this activity has been received from the following contributors. The on-demand recording and slides from this webinar will be available within 24 hours. And just to discuss navigating this activity, a separate window will show the poll questions. We invite you to submit your questions via the Q&A button. We apologize in advance if we're not able to address all of your questions in the allotted time. And just to note, the chat is open if you want to talk to each other or make some general comments. Now I'd like to introduce our speaker, Dr. Judy Levison, who is a professor in the Department of Obstetrics and Gynecology at Baylor College of Medicine in Houston, Texas. She completed her MD degree from Tufts University in Boston, her residency in OBGYN at the University of Washington, and her master's in public health from the University of Texas School of Public Health. From 2002 to 2022, she led the Harris Health System Women's Program, which provides obstetric and gynecologic care for women living with HIV in Houston, Texas. She is active in educating Texas healthcare workers about the management of HIV, and she's on the National Perinatal Guidelines panel and provides consultation for the National Perinatal Hotline. Her work in the area of HIV has led her to consult on projects worldwide in multiple countries, including Eswatini, Namibia, Ukraine, and the Dominican Republic. And she's been at the forefront of efforts to ensure that voices of women living with HIV are heard and respected, spearheading efforts to reconsider and revise infant feeding guidance. You'll hear much about this issue and her work and what I know is going to be a fabulous presentation. Now over to you.
Thank you so much, Elaine. And I thank the organizers for inviting me to share where I think we are in 2023 with the issues of breast chest feeding among individuals with HIV. So I'm first going to ask you to tell me your primary role. Are you a clinician, researcher, pharmacist, social worker, case manager, patient navigator, government employee, community advocate, lactation consultant or specialist, commercial company employee, or other? I'd like to know to whom I'm speaking. Okay, great. So we have 47% clinicians, 9% researchers, 16% pharmacists, 11% social work and related, and 9% government employees, and 1% lactation consultant specialist. Great. Thank you so much. There we go. I'm going to start with a question for all of you. And you have a patient with HIV who is considering pregnancy and would like more information on breastfeeding. You inform them that the risk of HIV transmission via breast milk from a breastfeeding person on antiretroviral therapy with a consistently undetectable viral load is 1, 20%, 2, 10%, 3, 5%, 4, less than 1%. Okay, and 3% said that it's 10%, 4% said it's 5%, and 93% said less than 1%. Thanks. Question 2, discouraging breastfeeding may contribute to health inequities. True or false? Okay, and we have 95% saying true and 5% saying false. Great, thanks. All right. So first of all, I may use breastfeeding and chest feeding interchangeably. When I say breastfeeding, I also ask you to hear chest feeding. Research that's been done in the past on this topic has been investigating cisgender women, and so results are usually reported as women. But if I slip, and we've been trying more and more to talk about people with HIV who opt to breastfeed when we're just talking in general. But if I slip, please forgive me. So I'm first going to give you some background to where are we and how did we get here? So once upon a time, prior to antiretroviral therapy, the risk of perinatal transmission in the US was estimated to be about 25%. And when I say perinatal transmission, what I'm talking about here is mother-to-child transmission during pregnancy, labor, and delivery. And then in the 1990s, someone got brave and decided that they would dare to give an antiretroviral to a pregnant woman. And zidovudine during pregnancy and labor, and then prophylaxis for the infant after delivery for 6 weeks was introduced. And the transmission was 8%. That was a 60% drop. And we realized that, having pregnant women on antiretrovirals can make a major difference. Then with full antiretroviral therapy, 3-4 drug regimens, fell to less than 1%. And we now have evidence that with antiretroviral therapy and undetectable viral loads at conception, throughout pregnancy, and at delivery, and this is now just in the last year, over 5,000 mother-baby pairs were reported on, the transmission was 0. So what's the HIV transmission rate through breastfeeding? What's the evidence? So we think what we have, the information that we have is the risk of transmission by breastfeeding prior to the availability of combined antiretroviral treatment. So this is before we were doing any of those interventions and providing antiretrovirals. In the US was about 16%, and that's just too high. So the question then was, well, what's the transmission rate with antiretroviral therapy in low resource settings, first of all? And so when we add the antiretrovirals, what happens? So I'm going to go through a sampling of some of the studies that we have relied on to move forward. The Keisha study looked at maternal treatment while breastfeeding, had 805 mother-baby pairs, and women were maintained on triple antiretroviral therapy. And at that time, this was also twice a day, which I do think makes a difference. It's more onerous. And it was until cessation of weaning at 20 weeks after birth. And these women had a lower risk of HIV transmission to their babies at a 12-month follow-up of 5.4%, compared to women who did not get ART and whose babies received prophylactic ARVs. And that was just single-dose nevirapine at birth and zidovudine twice daily for a short period of time, just for the first week of life. So it was not prolonged prophylaxis. And the second group was 9.5% transmission. So clearly, women on medication seemed to do better, and their babies did better than moms who were not. Then the Madonna study done in Botswana again looked at maternal treatment while breastfeeding. And they also had 560 women. They did BID dosing during pregnancy and followed the women for up to 6 months of breastfeeding, and found that this regimen was associated with a 1.1% cumulative risk of transmission. And here they were paying attention to viral loads, because do recall that a decade ago, getting viral loads, especially in low resource settings, was often difficult. And what they were able to show that women, that 90+% of their women had viral loads less than 400, high 70s to 80% had viral loads less than 50 during breastfeeding. And I think just as you think about this, not all of these women would have been ideal candidates in our view in 2023. The BAN trial then looked at infant prophylaxis versus maternal treatment while breastfeeding. They had over 2,000 mother-baby pairs. And so they compared the infant being on daily nevirapine throughout breastfeeding versus maternal antiretroviral therapy. And again, it was mostly zidovudine and lamivudine with lopinavir, ritonavir twice a day. And they had a control group where the baby just received 1 week of neonatal antiretroviral prophylaxis. At 6 months postpartum, the transmission risk was 1.7% in the infant prophylaxis group, 2.9% in the maternal therapy group, and 5.7% in the control group. And statistically, there was no difference, significant difference between the 1.7% and 2.9%. So it looked like there were options of either treating the baby or the mother. And so following that, the WHO in 2010 said, okay, to all our global countries, you governments have a choice. You can treat the baby with daily nevirapine until fully weaned. That was called option A. Or you can treat the mother with antiretroviral therapy until the baby is fully weaned. And that was called option B. What most countries adopted is what has been called B+, which is where mothers were started on antiretrovirals, and the idea was to keep them on for life, both for their health as well as for future pregnancies. And then one other comment was made was that exclusive breastfeeding was advised in low resource settings because of the high infant mortality secondary to malnutrition and diarrheal disease when formula was used. And I'll just tell you an experience I had. I was sitting at a cafe in Gaborone, Botswana, and you know the little containers in the middle of the table next to the salt and pepper, where they have the containers of sugar and artificial sweetener and creamer. And I picked up a package of creamer, and on it, it said, "Not for infant nutrition." And it dawned on me that this was a warning in response to people using creamer as an alternative to formula. They're both milk substitutes. You walk into the grocery store and formula is very expensive. Creamer is not so expensive. And so clearly some people had been giving creamer to their infants. So that was just one other side reason that the exclusive breastfeeding came in, but more the unsafe water. And also people sometimes diluting the formula because they couldn't always afford it or it wasn't always available. One other study we'll look at is HPTN-046. And that looked at placebo or long-term infant prophylaxis while breastfeeding. There was no difference in HIV acquisition among babies given placebo versus 6 months of nevirapine if the mother was on antiretroviral therapy. However, infant prophylaxis decreased acquisition of HIV if the mother was not on antiretroviral therapy. And so what we've come to, or many people have concluded from this, is that there's no benefit to prolonged infant prophylaxis if the mother is on ART. I think a question people have asked recently was, well, what if the mother misses some doses? And is there any benefit to the baby? I leave you with that question to ponder. So where are we in 2022? Well, we started with the 16% transmission via breastfeeding without ART. And then with ART, well, the original studies had suggested 1 to 5%, but most did not include strict correlations with the mother's viral load. The PROMISE study randomized mother-baby pairs to either maternal ART or infant nevirapine while breastfeeding. And this is our most recent large study. And what it showed was a 0.3% transmission at 6 months and 0.6% transmission at 12 months, which is 3 per thousand at 6 months and 6 per thousand at 12 months. Statistically, you can also look at this as number needed to harm. And number needed to harm for the 6 months is 1 in 334, and for 12 months is 1 in 166. And then just one comment, because I think we've all been a little bit confused by some of the data prior to antiretroviral therapy, and that's regarding exclusive versus mixed feeding. In the late 1990s, Anna Katsuta showed that exclusive breastfeeding was associated with a lower risk of HIV transmission than mixed feeding. That's alternating breast milk and formula or solids. And what we haven't known is what about with antiretroviral therapy? And we really have no evidence that this is true in the context of maternal ART. However, many of us, including myself, have still been a little concerned about what if they accidentally give formula to the baby in the hospital? What does that mean? Does a woman have to then formula feed? And I just want to clarify that we really don't have evidence to suggest that there's a problem there. And just it's more in the general population, exclusive breastfeeding is considered to be best for infants. So who wants to breastfeed in the US? This is a composite of many of the patients that I have seen. A 32-year-old woman, originally from Nigeria, was diagnosed with HIV during her current pregnancy. During prenatal care, she communicated to her obstetrician her desire to breastfeed. She feared that not breastfeeding would raise suspicion in her community about her HIV status. And I will say that stigma remains in the US, but stigma in African nations remains higher. And I had one woman come to me saying if she did not breastfeed, she would need to move because in her community here in Houston, her Nigerian community in Houston, if she were not breastfeeding, it would be the equivalent of waving a red flag at the community saying, I have HIV. And if that was suspected, not only would she no longer be invited to anyone's home, but her child, even if HIV negative, would not be allowed to play with anyone's children. So I learned a lot from my patients about, this is not only about HIV transmission, but there's some heavy social wastes on people. So this woman had heard and read so much about breastfeeding being better for her baby, boosted immunity, fewer allergies, less obesity, fewer infections, and also for her own health, less diabetes, lower rates of breast and ovarian cancer. So she was referred to the local pediatric HIV specialist who reviewed the risks of HIV transmission via breastfeeding. The patient expressed relief to discuss her concerns with a provider. Knowing she had options provided a space for her to contemplate the best decision for her situation. She opted to breastfeed for 3 months, both to prove to her community that she did not have HIV and in response to public messages that breast is best. She remained virally suppressed on antiretrovirals while she breastfed. Her baby was given daily nevirapine prophylaxis while breastfeeding, and which is the practice among our pediatricians, and we'll get into this a little bit more later. Her baby remained HIV negative. So this is just one common example, but there are certainly women in other racial and ethnic groups who are expressing a desire to breast and chest feed. So why doesn't every parent with HIV in the US just want a formula feed? Well, we had assumed that as long as formula was acceptable, feasible, affordable, sustainable, and safe, formula was better than breast milk in the setting of HIV. But as you've seen in the example, we have cultural norms to deal with. There is evidence that there's better infant health with breastfeeding. There is evidence that there's better maternal health. Many women are concerned with bonding with their infant. And in the last couple of years, the accessible and safe of formula we found is not always true in the US. We've had contaminated water in Flint, Michigan and Jackson, Mississippi, and extensive formula shortages, which put many women into a panic. Then we have the ethical arguments, and I'm going to quote directly from Marielle Gross, who I think has articulated this so well. Current recommendations against breastfeeding likely further disadvantage already disadvantaged women and infants, largely due to existing socioeconomic and racial disparities. Unfortunately, minority women suffer disproportionately from diseases breastfeeding may prevent, such as obesity, hypertension, heart disease, stroke, depression, and female cancers. And I think in this world, as we're trying to look beyond what had been current standards and really try to listen to people a little bit more and to reduce inequities, this speaks to me. So then comes the question, does U equal U? Well, we know that preconception, U equals U, if a partner living with HIV is taking antiretroviral therapy daily and has an undetectable viral load, you protect your partner. No transmission. During pregnancy, U equals U. For her baby, if a woman is on ART, pre-pregnancy, during pregnancy, and has an undetectable viral load at delivery. Postpartum, we have a lot of variables. And postpartum, we can't say U equals U when it comes to breastfeeding, but what we're recognizing is that each individual must do their own risk-benefit assessment. And one of the concerns and one of the issues complicating this as to does U equals U with breastfeeding is that of cell-associated versus cell-free HIV in breast milk. Cell-free HIV RNA seems to correlate with plasma viral load. And so you have a low viral load or undetectable viral load in your bloodstream. We don't expect to see cell-free HIV RNA in the breast milk. But even with undetectable plasma viral load and undetectable cell-free RNA, there appears to be cell-associated HIV in the breast milk integrated into the cells. Whether this cell-associated HIV is infectious or as infectious as cell-free HIV is not known. So that's an area that clearly needs more investigation. So again, why are we focusing on breastfeeding? now. There's clearly an increased interest in high resource countries, and some studies documenting that among 93 US clinicians who provide specialty care to women with HIV, 1/3 of the providers were aware that women in their care breastfed their infants after being advised not to do so. And then a survey of 15 centers in Germany showed that the number of women with HIV who had opted to breastfeed increased between 2009 and 2016 from 0 to 2 annually, and then from 2017 to 2020 from 9 to 13 cases annually. So all around the world, there's this new interest. And this is I think, an absolutely lovely study that was initiated by a group of pediatric residents who've now moved on to fellowship. They're from UCSF. They presented this as a poster in April, and the final proofs I saw last night, and it's been accepted for publication. They sent out surveys to US-based providers. They had 100 respondents. 10% of the respondents said they had an institutional protocol for care of people who breastfed, chest-fed. 42% had cared for someone who had breast or chest-fed. And I think that the illustration on the right really is a good summation of the provider discomfort that many of us have faced as we've had discussions about breastfeeding with some of our patients. So on the informed choice side, we have recognizing autonomy, and I'll tell you some of the quotes related to that. From a clinician, I will always support and provide care for an individual who desires to breastfeed, even if it is not my recommendation. Ultimately, even though it makes me uncomfortable, what's best for the patient is to remain engaged in care. Then we have extensive counseling, provide them information so they can make an informed decision. If there's increased risk of transmission, I would be sure they understood this. Reduce patient risk of transmission, or risk reduction. I would try to help her get a place where she was as low risk as possible to breastfeed, that is, on meds and virally suppressed with good lactation support. And then as to interdisciplinary teamwork, our perinatal team reviews and discusses options, and joint patient provider decision-making express our formal recommendation. So just this is the weight on autonomy. And then we look at the other side, which again, I think we've all been there or still are there. And one is persuasion. I would likely try to persuade her to formula feed instead. Compel using medical legal risk. Mother with HIV, undetectable prior to and during pregnancy, decided not to breastfeed because CPS was called during delivery, hospitalization, and mother was fearful of legal implications. Defer to hospital policy. Our hospital policy is a strict no breastfeeding with HIV, no matter the viral load or compliance with treatment. Refusal to provide care. Some clinical staff have refused to care for people living with HIV who choose to breastfeed, even if the person fits ideal conditions. It has been very time-consuming and emotionally distressing, both for providers and for people living with HIV, to discuss breastfeeding as an option. So I think these are very real examples of this tension that OBs and pediatricians have been dealing with in the last decade related to breastfeeding. Also, the National Clinicians Consultation Center at UCSF is the 24/7, 360 days a year hotline where clinicians can call if they have questions about pregnancy and HIV. And so if it's 3 a.m. and there's a newly diagnosed patient with HIV and you're not quite sure what to do, the perinatal hotline is there for you. And they've tracked what the topics have been of some of the calls. And as you can see on the right, From 2014, it was under 5% of the calls had to do with breast chest feeding. And by 2022, it was over 25%. So where do we stand? This panel is from the December 2021 perinatal guidelines. And this is going to change dramatically, but I just want to point out to you some of the language. And it said in the United States, infant formula feeding is a safe alternative to breastfeeding in individuals with HIV. Breastfeeding presents an ongoing risk of HIV exposure after birth because suppressive maternal antiretroviral therapy significantly reduces but does not eliminate the risk of HIV transmission through breastfeeding. Therefore, breastfeeding is not recommended for individuals with HIV in the United States. It's followed with individuals who have questions about breastfeeding should receive patient-centered evidence-based counseling, and individuals with HIV who choose to breastfeed should be supported in risk reduction measures. Call the perinatal hotline if you have questions. So that's where we have been for the last little over a year. And what's happened, and just a little bit of history on the guidelines, up until 2015, basically, they said no breastfeeding. And many of us were seeing patients who were going to breastfeed, and we could say, don't do it. But I certainly had the feeling that I would much rather have my patients breastfeed openly so that we could support them in doing it in the safest manner possible than to push them under the radar. And so 2015, a sentence was added to the guidelines saying individuals may face environmental, social, familial, and personal pressures to consider breastfeeding despite the risk of HIV transmission via breast milk. And it just said this needs to be discussed early in pregnancy. 2018, a full section on breastfeeding was added. And what we're doing now, and we'll see the final version has been the final version with multiple edits this past week, should be released at the end of January. And what we've done is we've really moved the discussion toward shared decision-making. One other huge decision was made by CDC. CDC had their own recommendations, and some of them were dated back to the 1980s. And if you go to CDC and breastfeeding, if you Google that, there are different kinds of comments on multiple CDC websites. So CDC said, we will defer or to refer to the perinatal guidelines so that we have one set of guidelines rather than two. And I hadn't realized until talking with some community members who pointed out to me that their physicians who might not be familiar with the perinatal guidelines, where do they go? They go to CDC. That's where I go, when there's a topic that I'm not so clear on. And so getting the CDC and the Department of Health and Human Services perinatal guidelines in line is really, I think, a real public service. So development of the 2023 guidelines, it involved integration of community input from members of the Well Project, which is I would say an advocacy group for women living with HIV, and from many other individuals. We had the recognition that restricting breastfeeding might increase the inequities, as Mariel Gross outlined, and because of the, here we had a chance to reduce obesity, diabetes, female cancers, hypertension, and maybe we were missing a chance. The other big thing was that we coordinated with the pediatric HIV panel. And before we had our guidelines, they had theirs. And what was, even though it was more work, I think it's just, I'm really proud of the collaboration, because this way the perinatal panel is dealing with some of the counseling issues and what we do during pregnancy. And the pediatric panel is dealing with the issues of antiretroviral management of HIV-exposed infants. And that's this question of prophylaxis. And I feel like we are now much cleaner in terms of how we are approaching this. So these may not be the final words, but this will give you the gist of the greater focus on shared decision making. And so in place of those bullets that I showed you from 2021, people with HIV should receive evidence-based counseling to support shared decision-making about infant feeding. Counseling about infant feeding should begin prior to conception or as early as possible in pregnancy. Information about and plans for infant feeding should be reviewed throughout pregnancy and again after delivery. During counseling, people should be informed that achieving and maintaining viral suppression through antiretroviral therapy during pregnancy and postpartum decreases breastfeeding transmission risk to less than 1%, but not 0. Replacement feeding with properly prepared formula or pasteurized donor human milk from a milk bank eliminates the risk of HIV transmission to the infant. Replacement feeding is recommended to eliminate the risk of HIV transmission through breastfeeding when people with HIV are not on ART or do not have a suppressed viral load. During pregnancy at a minimum throughout the 3rd trimester and as well as at delivery. And I think this at a minimum through the 3rd trimester is also relevant to the Flynn studies where there were a couple of cases of transmission that occurred in women who had undetectable viral loads at the time that their baby seroconverted, but if you look back, had not been the ideal candidates because they had detectable viral loads at delivery or shortly before. So I think that this is an important point. Individuals with HIV who are on ART with a sustained undetectable viral load who choose to breastfeed should be supported in this decision, and engaging child protective services or similar agencies is not an appropriate response to the infant feeding choices of an individual with HIV. There may be other social reasons associated with infant feeding that are worth reporting, but the infant feeding alone it has led to some pretty horrible outcomes and mothers and babies being separated. So what are our challenges as we go forward? Until recently, we had no studies done in high resource countries. It had been assumed that lactating parents with HIV would formula feed. So sometimes we've been asked, why can't we just rely on the African studies? Well, those data and conclusions may not be generalizable, and specifically meaning that the generalizability is a measure of how useful the results of a study are for a broader group of people or situations. You don't know if these studies are generalizable till you do similar studies in other populations. So far, what we have is a series of 3 infants from Canada reported in 2020. We have 10 from Baltimore and 8 from Washington reported last year, 13 from Italy, and 30 from Germany. And those studies illustrate the issue of what should we be doing with the infant. All of these mothers are on antiretroviral therapy. Does the infant need prophylaxis? And, does the infant need anything beyond prophylaxis for 6 weeks? Or I think it's going in, the British have gone to 2 weeks. We're somewhere in the 2 to 4 week range. Or should it be prophylaxis through the month after cessation of breastfeeding? And in the 2021 US guidelines, what we said was if the mother is receiving ART, and really should say ART and has a consistently virally suppressed, infant ARV prophylaxis can be discontinued after 6 weeks. Some experts in the US have felt more comfortable with continuing infant ARV prophylaxis through 1 month after cessation of weaning, even when the mother is receiving ART. However, during the HPTN 046 trial, which we talked about, in which the mothers received ART, there was no difference in postnatal transmission when the infant received nevirapine or placebo, suggesting no additive effect. So we have that. And then we have some groups that have given full antiretroviral therapy through full 3-drug regimen until 1 month after cessation of breastfeeding. And is that overkill? So we really don't know the answer to this. And I think so far, clinicians have gone with what felt best to them. What we've done is we have just concluded a multi-site retrospective chart review looking at patients between 2014 and the present. We collected data from 11 sites in the US and Canada and 72 infants. 21 of those were reported in the Canadian and Baltimore, Washington, DC studies. So we have 51 new infants. And our goal was really descriptive. We just wanted to have a baseline understanding of what are the reasons people choose to breastfeed or are interested in chest feeding. What are the current practices among obstetricians, pediatricians, infectious disease clinicians? And in many practices, it's the obstetricians are seeing the patients just for OB, and the pregnant individuals are seeing their ID doctor for the HIV issues. So it's not only the obstetricians and pediatricians who need to be aware of this, but the ID docs need to be on top of this too. We were also interested to see, were there institutional guidelines? How frequently were women having their viral loads checked? How often were babies being tested for HIV? What was the real life practice regarding exclusive versus mixed feeding? And what situations were associated with HIV transmission while breastfeeding? So we hope to submit the manuscript this week, and we will be presenting some of our data at the HIV and Women's Conference in Seattle in February. But we still, after describing, we're still left with questions of who are considered good candidates for breast chest feeding. How often should we be checking maternal viral loads? How are pediatricians navigating, and how should they be navigating the role for infant prophylaxis beyond the first 4 to 6 weeks? Are breastfeeding and formula both being used? And how do we reach clinicians and parents about changing thoughts on breast chest feeding and HIV? So what we're hoping for in the future, we hope we see some qualitative studies to hear more about pregnant lactating individuals and clinicians' lived experience about decisions to breastfeed or formula feed. We'd like to see some prospective studies enrolling women during pregnancy. And do we want a national registry? And if we do, who should manage that? So I thank you, and I am open to questions. We will do the post questions though. So you have a patient with HIV who is considering pregnancy and would like more information on breastfeeding. You inform them that the risk of HIV transmission via breast milk from a breastfeeding person on antiretroviral therapy with a consistently undetectable viral load is 1, 20%, 2, 10%, 3, 5%, 4, less than 1%. Okay, and the risk is less than 1%. We actually had some shift. All right. And oops. And then next question is, discouraging breastfeeding may contribute to health inequities, true or false? And we had 98% saying true, 2% saying false, and I hope I have given you some evidence to that I think this is true. All right. And, great.
Great. So I think I'm back on now. And I have the pleasure of presenting some of the questions that have filled up the Q&A. Luckily, we have plenty of time. So I'll start by sharing some of these questions. So there are two which are sort of straightforward. For women living or people living with HIV, are we considering undetectable viral load less than 20 or less than 200?
That's a great question. It depends, yeah, whose study it is. We went, so I think internationally, I believe, and Elaine, you can correct me, I believe less than 200 is considered undetectable, but we've been usually relying on less than 50, even though in the US, many labs go lower, but less than 50 is what we use for our multi-site study. I don't know, any comment?
I think the newest guidelines are saying the lower limit of detection being 50 or 20, but
Okay.
certain that's, I think, the way that the guidelines are phrasing the
Okay.
next version. There any data on proviral load in breast milk cells on mothers on ART and suppressed viral load?
I think we need data. And also it's not just the presence of it, but is it infectious? And yeah, so I think we need more information.
So you touched on the topic of mixed feeding and some providers' hesitations. This person indicates it seems stressful having to exclusively breastfeed if having issues with supply, time to pump, all of those things we're familiar with. How do you practically navigate this conversation in your practice?
Okay. And this is a moving target for us. And actually, until some recent discussions with Elaine Abrams, we were still thinking that, do we have to be concerned about mixed feeding regarding transmission? And our pediatricians were equally concerned. And I'm also, I think there was a question I'm just going to address, like, what, why would it make any difference, even in the days when there were no antiretroviral therapy? There were different theories, first of all, that started this concern. And the theories were that the first theory was that if a mother used formula intermittently, formula is not physiologic. And we know that sometimes babies will try one formula and then they'll go to another and another before they find one that sort of sits well with their gut. So the idea was that formula may irritate the infant's gut, and then if a mother chased that with HIV-infected breast milk, the HIV would get into the inflamed portals of the gut, because where there's inflammation, then we know that there is easier access to HIV. So the first was related to infant gut. The next theory was it had to do with the maternal breast. And that was that if a woman is often on breastfeeding, she's going to have more engorgement. Where there's engorgement, there is inflammation. Where there's inflammation, there's HIV. And so that was just the other theory. But I'd say really just during these last 6 to 12 months, as we've worked on the new guidelines and we've had more and more discussions about it, it's become more and more clear that we don't have evidence when people are on antiretroviral therapy. And even though I will tell you, a year ago, we had an incident in our hospital where a baby was inadvertently given formula, and then everyone was up in arms, like, oh no, as I mentioned in the talk, that what do we need? What do we do? Do we allow the mother now to breastfeed, or does this sort of ruin it? And I think I can think of one case where she was switched to formula, another where she was allowed to go on with breastfeeding. And I think we are moving more and more. And again, part of this is listening to the community. In reality, there are going to be times where somebody needs to use formula. And I think we have softened our views on that and are leaning more towards saying, you know what, that evidence doesn't, it's not related to the current scenario where somebody is on antiretrovirals. So we favor exclusive breastfeeding, both for maybe some lingering concerns over the HIV, but more so that's really what is best for baby. But I think that we're realizing that many of the women who've chosen to breastfeed have intermittently used some formula, sometimes not talked about it. And that if we're trying to be realistic and address the real needs of the community, we're going to make some room for occasional formula feeding.
So Judy, just to add to that, the very earliest studies that demonstrated a higher risk of transmission weren't necessarily with the addition of formula. It was actually other substances. So early introduction of solids, which is common in many communities in Africa where this was initially studied, right? And then the antiretroviral studies where women or babies are treated in the context of breastfeeding had paid less attention to measuring how mom is feeding. But the assumption is that in many of these studies, babies were not exclusively breastfed for 6 months as is recommended, and transmission rates were still extremely low. So that's a backdoor way to this conversation.
Yes, thank you.
Okay, so somebody is asking if the updated guidance in 2023 will provide guidance on the frequency of viral load testing during breastfeeding. And what will you do? And this is a question I think has come up a number of times. What do you do when mom loses suppression, right? Yeah. Much of this is discussed in the context of a suppressed viral load. What happens when that isn't the case?
Right. So one, yes, the new guidelines will say, will recommend testing the mothers every 1 to 2 months. And I think the big question has been, what if you have, I'd say, a 2-digit viral blip? So you're still under a viral load under 100, but it's 40 or it's 60. And I think what we are saying in the last iteration of the guidelines is repeat, first of all, because we know that if somebody has had a recent flu or something like that, they may have a blip in their viral load. But if you're seeing a viral load in the hundreds, that this is the time to have the discussion about something's not right here, and we need to talk about stopping breastfeeding. And I think that's one. And I think rightfully so that many pediatricians have said, but what if there's somebody who says, I'm not going to stop? And I'll be honest that has not, when we have had situations where someone really wanted to breastfeed but wasn't a good candidate or started to, and then we said, look, this is not right. We haven't had anyone who bucked that, and everyone really wanted to do what was right for their babies. But I understand, being proactive, you have to be prepared for that. And then, so if somebody says, no, I'm not going to stop, and you say, oh, but now your baby's really at risk, the question has come up whether that baby should be put on a high-risk protocol, like basically full therapy. Elaine, you want to comment?
So I'll make 2 comments. One is that there have also been updates to the infant postnatal prophylaxis guidance and what to do in these kinds of cases. And also to comment that the guidance is, I think, a little bit more hands-on and definitive in the context of early or acute maternal infection. So if a woman who's breastfeeding is determined to is newly found to have HIV infection, there is suggesting that she really be counseled to stop, right? Because in that case, there's very high risk of transmission.
Right.
So that's what I'll add. Several people are asking if there are particular ART regimens that mom should be on during breastfeeding, and do we know anything about a transfer of ARVs through breast milk to the baby?
There is no particular regimen. There recently were a few studies that were published that were completely contradictory about, it was, I believe, levels of, I think it was dolutegravir, maybe it was TAF. And we were going to put something in the guidelines, and then the exact opposite came out in a different study. And so I think there's still not, that we don't completely know. And then, but we certainly, if from the low income settings, we've had women for decades now, on antiretrovirals who have breastfed, and we are not aware of any bad effects. In general, the percent of that's detected of the drugs in breast milk is very low.
It depends on the drug. There have been several reports, papers around dolutegravir. It is relatively low. Efavirenz was detected in babies. The NRTIs tend to be lower, so it's quite drug specific. The PIs, I think, not at all. So and I think there is some concern on the internationally, where women are on many women are on suppressive ART and breastfeeding, whether there may be some impact on infant diagnostic testing and the timing of tests and when you can detect infection, particularly adding in some breast milk exposure. So that's going to unfold, I think, over the next years. Angela Culvers just wanted to note that there were 21 cases reported from the Swiss as well, including breast milk concentrations of ARVs. Let's see. Somebody asked, would like to hear more about the thinking about why data from African women may or may not be generalizable in the US.
I think one is just because some of the studies were not following the careful viral load monitoring. I mean, some of the earlier studies, we just, we really don't know what was happening. And just, yeah, we don't know. Adherence issues, I'm not saying it's better here. But in fact, it may be worse, but we don't know. How do people do with adherence here versus other places? One thought is that women will be extra motivated to be adherent if they are breastfeeding. And but we also know there are other studies showing that there are challenges postpartum, and mom's taking care of a few kids and doesn't make it to the pharmacy on time, and things like that, or insurance issues. So I think those would be what come to my mind as to just why we do need some information from here.
Has harm occurred to infants receiving prophylaxis in spite of mothers having suppressed viral loads?
That's for Elaine. It's a pediatric question.
So with the agents that we use, primarily nevirapine for prolonged prophylaxis, it's considered quite safe. I think the question arises of, do you want to give a baby any medication that they don't necessarily need during this particularly tender developmental period? As little as you can give is, if we want them to get just breast milk. But if we're balancing a potential risk, then I think you certainly wouldn't hesitate. What we don't know is if there's any benefit. If mom is suppressed, is there a reason? Is there any benefit to giving the babies daily agents? And that has never been tested. There's a lot of interest in testing that question, particularly with new agents, and thinking about long-acting agents or some of the newer, less toxic agents for prolonged prophylaxis. Let's see. My understanding is that transmission rates increase as the duration of breastfeeding increases. The data shared is up to 12 months. The updated guidelines should probably note that there's less than 1% risks for up to 12 months, and maybe a caveat that it's unclear beyond that. Is there a recommendation to wean at 6 to 12 months, or is there no guidance on this?
Yeah, I think we don't know. And, and I also, I have wondered, because I'm aware of those numbers, but again, those all came from low resource settings. And what I've wondered is, here, there's pretty strong recommendation, as I understand it, for babies to start with solids somewhere between 4 and 6 months, and then, progress rapidly to more and more solid food. And I just don't know, I sometimes have wondered about the quantity of breast milk they're getting exposed to here versus in another country, whereas if you don't have as much food available for your kid, are you going to be doing more breastfeeding? And I don't know if there's any dose related outcomes. And I don't know. And again, this on the pediatric side, again, I'll ask Elaine just if you have any thoughts on that.
Well, the World Health Organization infant feeding guidance basically recommends breastfeeding for as long as you do it, sort of up to 24 months up, and if needed beyond that. I think the 12-month cutoff is a legacy of this equipoise between trying to tell women not to breastfeed, not to expose too long. And the monthly risk doesn't necessarily change beyond 6 months. It's just the longer you breastfeed, the longer the possible exposure. And the more times you have sex a week, the more likely you'll be exposed. So as I said, I think the 12-month cutoff is a legacy from the past.
Thanks.
Yeah. If a person has an injury on their nipple that produces blood, cracked nipple, would that impact the conversation around feeding?
Yes. And if there's a bleeding lesion or mastitis, there we are recommending to pump from that breast and discard the milk. Breastfeed from the breast that's not affected. And ideally supplement with stored breast milk. Ideally supplement with stored breast milk. But if there isn't an adequate supply of that, this would be a situation now where we would say, well, maybe you use formula briefly. And I wouldn't have said that a year ago.
Do you think the move towards accepting or recommending breastfeeding in the West would be easier if long-acting ARVs are proven safe and given to breastfeeding women?
Sure, if they're, proven safe and somebody has got to do the, include the pregnant and breastfeeding women in the initial studies.
There's a study looking at the PK of injectable cabergoline in pregnant women in the Impact Network, and I believe there have been discussions around several studies looking at the breastfeeding period, but I don't know of any of those that have been planned.
No, great question.
What guidance can you provide for implementation at our sites? And I think this is referring to the new guidance.
Now, and that's a great question because, and I will tell you, at our hospital, my colleague Jenny McKinney is working with staff and pediatricians to get everybody on the same page. And we were approached by another center who they were going through the same thing, and like, who are all the stakeholders? And I think we've identified, so you have the obstetricians, you have the ID docs, you have the general pediatricians who are more likely to be present at the time of a delivery than the PDID people who may show up the next morning. You have the nursing staff who it's been beaten into them, HIV, no breastfeeding. The lactation consultants and lactation specialists who also have had that, no, we don't do that. And so I think that there really needs to be, everybody needs to be brought into the fold. My colleague, Jenny McKinney, is starting to do some change of shift talks for the nurses and whichever pediatricians are around and whichever lactation specialists are around. But I think, one of our questions, and I'm really open to input from attendees, is how do we get this word out? And not only in the hospital, but also outside. And example, I had one patient, in the beginning, we didn't have an agreement. Now we do have an agreement that women, there might maybe 12 to 15 points. I understand that there's a risk of transmission. I understand that, blah, 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 all the different points we want to make. And they initial each of the points. The obstetrician signs, the pediatric ID person signs, and the patient signs. And it was intended for the hospital to just be able to say, so that the staff would know this has been discussed. This mother didn't just make this up, on the fly, because we've had that too. We didn't anticipate that this agreement would be used in this way, but one of my patients went to WIC to get her supplementary food, and she said, I have HIV, I'm breastfeeding. And they said, oh, we'll have you talk to the lactation consultant. They said, fine. She goes to the lactation consultant, says, I have HIV, I'm breastfeeding. And the woman's eyes get big, and she said, I'll get back to you. And the next day, a CPS worker knocks on her door saying, I understand you have HIV and you are breastfeeding. And the woman pulled out her agreement and said, but my doctor signed it. My baby's doctor signed it. And the CPS worker sort of backed off, but said, I'll get back to you. And that happened on a Saturday, and she came in on a Monday, and we were able to contact the CPS worker, we were able to contact the lactation person. And the lactation person said, I appreciate your calling. I had no idea that this might be okay. And, it really pointed out, we need to get the word out, yes, to the organizations that do education for lactation also. But we've been talking a lot about going through American College of OBGYN, the Society for Maternal Fetal Medicine, American Academy of Pediatrics. There's an Academy of Breastfeeding Medicine, I think it is. We have HRSA, we have AETCs, we have, but what I'm really open, and if people have suggestions, please let me know.
Yeah, I just want to comment. There were several questions submitted in advance asking about the best ways to generate consensus among medical professionals based on the past behaviors and the reliance on law enforcement to dehumanize and criminalize people who breastfeed. So I think there's a lot of interest in that. I think it's going to take a long time.
Yeah, no, and I know there definitely are clinicians, and I understand their point of view, who are very much against this sort of the trend or of where the guidelines are going, and I apologize to them, but I think I just have to say my reality is people are breastfeeding, and I can't completely deny that. And so I'd much rather people do this openly. So
there's someone who's a medical director from a local health department in Michigan, and he suggests recommending engaging with state health departments about work policies, and we'll share this presentation.
Great.
I think that's a great idea, and there are a number of other fabulous suggestions in the chat. There are also quite a few questions about the infant postnatal prophylaxis, and I think it's probably not unreasonable to say that it is really there's a lot of controversy even among the pediatricians on both sides of the scale. How little can we give? For example, in women who've been babies born to moms who've been suppressed for years, right, and come to delivery and are not intending to breastfeed, do they need any prophylaxis? Can you just give 2 weeks prophylaxis? All the way to the other end of women who choose to breastfeed. Some pediatricians are uncomfortable enough that they feel should give those babies triple drug therapy. And if you read some of the cases in the literature, that's what's been done. So the pediatric guidelines will have new recs for postnatal prophylaxis. They're a work in progress, but they're probably address many of the questions that are in the chat. Let's see. Heard you mention high-risk infants. What ARVs do we give these infants? Is there any particular age when you shouldn't give an exposed infant prophylaxis? I'll take that. There is no particular age when you shouldn't give them prophylaxis. High risk is defined in the guidelines and is basically any baby born to a mom who isn't undetectable. The high risk will often get what's presumptive treatment for a period of time until you can determine there is no infection. A baby who's high risk probably will not be a great candidate for ongoing breastfeeding. So that's an important distinction. I think there's so many questions, but I think we've answered a great many of them.
And I will say that if your question wasn't answered but you would like some response, it is fine to email me, and my email is jlevison, JLEV as in Victor, ISON at BCM as in Baylor College of Medicine.edu.
Yes, I think we've done a great job with this. So, I don't envy your email because I'm sure you'll be hearing from many people this, which is great because this is a small revolution that's about to take place. So I want to thank you. This has been great fun. And I think we can turn it over to Jose now.
Thank you, Dr. Levison and Abrams, for a wonderful discussion and very informative presentation. As a reminder to our audience, evaluation and information on how to claim continuing education credits will be emailed by 5 p.m. Pacific time tomorrow, and this will enable us to review all of those that have attended today's live broadcast. Your feedback on our evaluations is really important to us, and we definitely encourage you to complete that in order for us to either improve our programs or continue, the valuable content that we are providing. If you're interested in hearing more from our speakers today, they will be a part of the Scott M. Hammer Annual Update on HIV Management in New York. And this course will take place on March 16th. Information will be made available on the IAS-USA website, and you can definitely register now. And then we have another course on March 31st. Again, for information, please visit our website. We continue to schedule COVID-19 dialogues and include other urgent virus outbreaks. To review our upcoming schedule as we post them, please visit our website. Lastly, CROI will be taking place in Seattle, Washington from February 19th through the 22nd.
And someone did, I think I did see the question, someone asked about the Women in HIV workshop. And that it's being held in Seattle the weekend, it's like Friday and Saturday before CROI. And it's called, I think it's called HIV and Women Workshop, put on by the Viral Education Group.
Thank you, Dr. Levison. And again, we'd like to thank our audience for your participation. And so this concludes today's webinar. Thank you.